So in current class, we are now focusing on the shoulder impingement syndromes. Okay. Again, a very important point which is missed by the residents as well as most of the consultants as well because of the lack of knowledge about this. Okay. So as the word impingement, it's basically entrapment of the musculoskeletal soft tissue within the shoulder, which results basically in pain. Okay. So this is the most common diagnosis which we get on a day-to-day basis in the shoulder joints which we report. But I haven't seen anyone writing any kind of word impingement uh, in that. Okay, so very simple. There are two types. One is extra-articular and one is intra-articular impingement. Okay, so one is basically inside the capsule. So the structures which are inside the capsule, it is involving that. And the extra-articular one, very simple, which is involving those structures which are outside the capsule. Okay, so again, these are very simple. Okay, so if you talk about the external shoulder impingement, okay, so what we are basically concerned about here is the supraspinatus outlet. So it's the space through which your supraspinatus passes. It's a narrow outlet. Okay. It's kind of an osteoligamentous tunnel, which is obviously surrounded by the bones as well as certain ligaments. Okay. So ligaments we all know. The most important one being your coracoacromial ligament, and the bony structures include your acromion, the coracoid, and behind we have is the, or on the posterior aspect we have is the humeral head. Okay. So this narrow portion is basically your supraspinatus outlet. You see the contents. So we have the supraspinatus muscle and tendon, that is basically the myotendinous junction as well as the proximal tendon. Then we have the supracromial subdeltoid bursa, and we also have the intra-articular portion of the biceps tendon, or you can say the portion of the biceps tendon in the rotator interval. So anything which causes narrowing of this space, okay, will lead to the impingement, kind of an external impingement. And since it is below the acromion, we use the term subacromial impingement. Okay, very important point, very simple, but usually missed. Okay, this is not reported in the most of the shoulder joints. Okay, so now the subtypes of external shoulder impingement, they can be primary as well as secondary. Okay, so all those who have joined late. Okay, so we have started with the shoulder impingement syndromes. Again, a very important topic post the shoulder instability. And in the next class, we'll be discussing your rotator tears. Okay, that's again a very simple topic. Okay, that's almost known by everybody. So that is why I've kept it at the last. Now, in shoulder impingement, we have two types. One which occurs inside the capsule, we call it as intra-articular impingement, and one which occurs outside the capsule, we call it as extra-articular impingement. Extra-articular one can be two types. One is primary and can be secondary. Primary is the structures which are surrounding the supraspinatus outlet. I just told you, there's some defect in those structural defects in those structures, which is causing the narrowing of the rotator cuff outlet. By the rotator cuff outlet, here we mean the supraspinatus outlet. Okay. Now it includes two types. One is your subacromial impingement, and we also classify the subcoracoid impingement under this heading only. Okay. In the secondary ones, there is no primary outlet stenosis, meaning there is no structural defect in the structures, but there is glenohumeral instability, which is causing this impingement. It is usually seen in young patients and overhead athletes. Okay. So there is laxity of the capsule, and because of the laxity of the capsule, the humeral head migrates superiorly, causing reduction in the subacromial space, leading to a functional impingement. Okay. The most commonly impinged tendon is the supraspinatus tendon. You need to remember this. The cause of pain in this is your bursa, because it causes bursitis. And then I told you biceps, the rotator interval part is also a content of that. So that pathologies can also be associated with the subacromial impingement. And what is the site of degeneration? As I told you, it is the musculotendinous junction of the supraspinatus. So anything which is the part of that content will get affected. So we have supraspinatus tendinopathy, tendinosis or tears, musculotendinous junction of supraspinatus. We can have the degeneration of that, SAST bursitis, and we can have certain pathologies of the intra-articular part of the long head of biceps as well. Okay. So this is just an MRI image of the sagittal oblique image, T1 weighted. So see, here is the coracoid process. This is your acromion. Hypotenuse band which is connecting the coracoid and acromion is the coracoacromial ligament, or you can say the anterior boundary of the coracoacromial arch. This here is your subscapularis. This is your humeral head. This is your supraspinatus, and this is your preterintral part of long head of biceps tendon. Okay. So you should be remembering this anatomy. This anatomy will be useful both when we will be discussing the adhesive capsulitis. Okay, so I'll simplify the adhesive capsulitis for you. Okay, it's a very confusing topic. Okay, most of the consultants, they are reporting on some basis, and there's no clarity about how to report a case of adhesive capsulitis. So I'll make it crystal clear for you what is actually adhesive capsulitis. Okay, so you need to remember this anatomy when we're discussing that. So what are the factors which can predispose? So we are not talking about the subacromial impingement. Subacromial impingement. So we're talking about a primary extra-articular impingement. So we need to have some structural causes. Okay. So let us discuss those structural causes. Okay. So we can have certain changes in the acromial morphology, like we can have abnormal configuration. Instead of flat slope, we can have downsloping of the acromion. We can have a low-lying acromion. The tilt of the acromion can be inferolateral. We can have an accessory ossicle, which is not fused with acromion. We call it as off acromial. We can have acromioclavicular joint disease, okay, degenerative, or we can have thickening of the coracoacromial ligament itself. So you see, these are all those structures which are basically forming the supraspinatus outlet. So any abnormality in those structures will lead to primary subacromial extraarticular shoulder impingement. Okay, so these have to be reported in the MRI reports. Okay, because most of the time the cause of the pain is actually these only. So modalities for bones, you'll look for radiography, very simple. Ultrasound, you can have dynamic assessments. Okay, MRI, you can see the condition of rotator cuff tendons, labrum, bursa, and any comment on the muscle atrophy or fatty infiltration. Okay. This I'm doing it fast because it's actually very simple. You all know about this. Why do we use different modalities in, for looking at different things? So this is the view which we use for the to see the outlet. Okay, so this is the supraspinatus outlet view, or we also call it as the Need's projection. So this is basically your scapula, the two arms of the Y. Okay, one is formed by the coracoid, other is formed by the acromion. This is the distal tip of the acromion. This is the lateral end of the clavicle. This is the AC joint. Okay, and this region is actually the supraspinatus outlet. So what things are all clearly visible? If there is some spur here, that will easily be seen. If there is inferior downsloping of acromion, that is also easily visible. So any bony factors which can lead to the reduction in the supraspinatus outlet space, okay, will be easily visible on this view. Okay. Now there's a classification. So this has to be reported in the MRI reports. You have to write what type of acromion process we see. It was given by Bigliani. Okay. So he described actually three types. Now the fourth type has also been added. Okay. If you look at the undersurface, if it's flat, it is type 1. If it's curved, or you can say it's concave, it is type 2. If it's hooked, kind of an inferior downsloping, it's hooked, it's type 3. And if it's concave upwards, it is actually type 4. Okay. So this is the prevalence. So you will see the type 2 is the most common here. And the highest amount of risk, very obvious, is associated with the type 3 because of its hook morphology. So very high risk of subacromial impingement. Okay. So type 3 has the strongest association with rotator cuff tears, and you have to write in the report that there is note which is made up of type 3 acromion morphology based on Bigliani classification. Okay. So flattened, type 1, concave, type 2, hooked, type 3, concave upwards, it is type 4. Okay, so you see the maximum reduction in the subacromial space is seen in this case. Now, another cause we can have unfused accessory ossicle of the acromial joint. We call it as os acromial. Okay. The main pathogenesis behind this I'll discuss. So the acromion process has three ossification centers, by the fusion of which the whole of the acromion process is formed. So one which is near to the lateral end of clavicle, which is actually the joint forming. We call it as preacromion. Adjacent to that, we have the mesoacromion, and another we have the metaacromion. Okay, so this part may not be fused with this, or this part may not be fused. So we can have almost 7 types of combination. So we don't need to go into details for that, but just we need to know if we see a or subacromial, it's very easy to identify on a radiograph, but it's sometimes can be challenging or it can be easily missed on an MRI because we have to see the most cranial most section so as to see whether we have a or subacromial or acromial or not. So it's very important first to see on the superior most axial MRI section. Okay. Why this is important? Why the reporting of os acromial is important? Because it usually acts as a substrate for subacromial impingement. What happens is the deltoid muscle is attached to this os acromial. Okay, whenever there is downward pulling of the deltoid, okay, so this os acromial will be pulled downwards into the subacromial space, or you can say the acromiohumeral space. It will lead to reduction in the subacromial joint space, ultimately leading to the subacromial impingement. Second thing, we can have there is a synchondrotic joint at the main acromion body and the os. Okay, so in that we can have osteophyte formation here. Okay, that can also lead to narrowing. Okay, in patients who are having ossicromial, there is increased incidence of AC joint arthritis. One is this, and if the ossicromial is unstable, it can allow the downward pull of the deltoid muscle, like which I've told you. Now let us see some images here. Okay, so you see there's a T1 weighted corneal image. Okay, you see there is a synchondrotic joint between this is the os subacromial, and this is actually the acromion process. Okay. Now, this is a deltoid muscle which is attached to this, and because of the contraction of the deltoid, there's a downward pull which is occurring on this unstable ossicromial, which is reducing the acromiohumeral space. Okay, so it increases the patient's risk for subacromial impingement. Okay, so very simple. The important point here is you should be knowing that something like this exists and it needs to be reported in the report for the orthopedician. Okay, so that this os acromial is also managed along with if he wants to operate for some other thing. Okay, this very simple acromial spurs. Okay, should we have the knowledge? You should have the knowledge of these spurs, and you should regularly report these in your MRI reporting. Okay. Now there are different types of spurs. Okay. Obviously, they are formed because of the traction of the ligaments. Okay. And main one point which you need to remember is if it's more than equal to 5 mm, if the length of the spur is more than equal to 5 mm, it has a very high diagnostic value because it is strongly associated with bursal-sided tears. Okay. So obviously this is the supraspinatus tendon. This is your humeral head. This is the AC joint. Okay. So this is your articular side and this is your bursal side. So we have discussed all of this in the anatomy of the shoulder joint. So any spur obviously would be causing bursal-sided tears. Okay. So remember the length more than equal to 5 mm, very strong association. Let us just look at some pictures of these spurs. You can easily identify those. Okay. So any spur which is from the inferiorly from the undersurface of the acromion but it should be away from the AC joint. Okay, this we call it as heel type of spur. Okay, heel type of spur. Okay. This also has to be reported in the X-rays as well. Don't miss these. Okay, so this is the heel type of spur. Okay, you have to mention this in your reports because this patient is at an increased risk of shoulder impingement. Okay, again, this is the heel type of spur. Then we can have spurs which are laterally protruding. Okay, like this. This is a laterally protruding spur. Okay. This is another example for the same. Okay. Again, these are at less risk as compared to, I'll show you the another one, lateral bird beak type spur. Okay. So this was your laterally protruding spur. So this was congruent with the undersurface of the acromion. So this was actually not actually causing any narrowing. Okay. Which I almost missed 40 slides. Okay. Okay. So don't worry. We are here discussing the causes of subacromial impingement. Now we are basically on the spurs. So we are discussing different types of acromial spurs. Okay. We started with the first one. So this was the quadrangular type or heel type of spur. It should be away from the AC joint. Okay. Just see the images and try to look in your MRI cases when you do day-to-day reporting. There is nothing to learn as such. You just have to have knowledge that such type of spurs exist and try to look these in the MRIs. Okay. And then try to mention these in the reports, both on the radiographs as well as the MRI, if you get. Okay. So there's nothing to cram here. Then laterally protruding spur, I told you this is congruent with the undersurface, so not much role in impingement, but this bird beak type spur has a role in impingement, okay, because it is protruding down into the acromio-ventral space. Just look at the images, okay? So this is a lateral bird beak type of spur. Why we are saying lateral? Okay. What section actually we are seeing here? We are just seeing the coronal section here. Okay. So this part is the medial side and this is your lateral side. Okay. So on the lateral side, we have a protruding acutely angulated spur on the anterolateral inferior surface of the acromion. Now we can have medial type spurs. This we have seen at most number of times. This is seen with AC joint arthritis. Okay, so spurs on the distal end of clavicle as well as the acromion. Very simple. Okay. So this is associated with AC joint arthritis. Okay. Yeah. So this is the spur. Okay. Again, these are the spurs. You can see there is narrowing of the joint space. There is some sclerosis as well. If you look carefully, you can see these spurs. You just have to add one line in your report. So you see AC joint arthropathy with medial sided undersurface acromion as well as distal endoclavicular spurs compromising the acromio-humeral interval space. Okay. Now, so we were discussing the lateral side spurs. Now we can have anterior spurs also. So for anterior, we'll use the sagittal oblique images. Okay, that's obviously a common sense, very simple. So this is a sagittal image. This part is anterior because we see the subscapularis. This is your infraspinatus. This is your teres minor. So this is the posterior aspect. Okay. So now you will see the spur which is directed anteriorly. So again, we can have traction spurs. Okay. So they are congruent with the undersurface of the acromion. And again, we can have, or you can say anteriorly protruding spurs and anteriorly bird beak type spurs. Very simple. Okay. So very nicely seen here. Similarly, bird beak obviously had an acute angulation. Okay, simple. Okay. So they have very strong association. The heel types was actually they have the most highest risk of association with full thickness rotator cuff tears. Okay, and patient they should be closely followed up. Then obviously we can have AC joint degenerative changes. You will have medial type of spurs, and that can also contribute to the primary narrowing of the supraspinatus outlet. Okay, now just let us look at certain more images. Okay, just look at the images. No need to cram these. We can have anterior down sloping of the acromion. Then we can have an inferolateral tilt of the acromion. Okay. There's no objective criteria as such, but there's just all the structural causes which can lead to narrowing. And then we can have low-lying acromion. Now, cause could be any. Okay. We can have post-trauma, post-surgery, anything. Okay. So anything which leads to low-lying acromion. So all of these things will reduce the acromio-humeral interval space. So what all MRI findings you can get in this? You can obviously you will be getting bursal sided partial thickness tears in the supraspinatus, and so again these are just examples. This is an anterior Birdwig type of spur or an anthesophyte. Inferolateral tilt of the acromion. Again an anterior anthesophyte. Now, what we are concerned is with the objective criteria, you have to measure the acromio-humeral distance. So you have to measure the cortex from the inferior surface of the acromion to the superior cortex of the humeral head. Okay. So the minimum distance you have to calculate between these two. So minimum is 7 mm, maximum is 11, and the average we take it as 9 mm. So anything which is less than 7 mm indicates subacromial impingement. Okay. Okay. Now there are some other points also which can cause increased risk of subacromial impingement. So there can be certain excessive coverage of the shoulder, uh, basically your humeral head by the acromion. Okay. So you can very well measure this by the critical shoulder angle. Okay. But you should use this only when you're suspecting this, when you see that there's certain abnormal over coverage of the humeral head. Okay, so this I'm telling you because sometimes you may see this, but you will not be knowing how to describe this in your reports. So if you have heard this somewhere, you will obviously try to look at. So you draw a line which is joining the very simple superior and inferior aspects of the glenoid, and one from the inferior aspect of the glenoid to the lateral most aspect of the acromion. And you measure this angle. Okay. So if it's more than 35 degrees, it's also again associated with subacromial impingement. Okay. This much you should be knowing. So this was all about the subacromial impingement. Okay.